अस्सलाम वालेकुम। आज हम अपना नेक्स्ट टॉपिक स्टार्ट करेंगे पोस्ट नेटल पीरियड। एपिड्यूरल एनेस्थीसिया which is also known as extradural or peridural pain relief for labor. The benefits of epidural anesthesia: it may be administered as a single dose, as continuous infusion, or as client controlled pump. Low dose epidural adding an opiates to reduce loss of mobility if appropriate is now available in some areas. ये हमारे पास लोकेशन हो गई एपिड्यूरल एडमिनिस्ट्रेशन की। या तो हम L3 L4 के दरमियान लगा रहे होते हैं क्योंकि L2 लेवल पे स्पाइनल कार्ड एंड होती है, उससे नीचे नीचे हम अप्रोच करते हैं ताकि कोई न्यूरोलॉजिकल इंजरी ना हो। The mother will be fully conscious, her mind unclouded by analgesia. She will be able to welcome her baby with an alert mind. The effects of bupivacaine on the baby are minimal compared with those of the pethidine. Epidural anesthesia may be helpful in cases of pre-eclamptic toxemia and in coordinate uterine activity. For complicated deliveries like twin, breech, or forceps, epidural anesthesia provides the obstetricians with the conditions needed for control and hence the safety of the baby. Cesarean delivery can be carried out under epidural anesthesia. The mother can be awake and will escape the unpleasant after effects of general anesthesia and its dangers. Technique: an IV infusion, usually hot mint solutions, is always set up beforehand. The mother will either lie on her side curled up as much as possible. पहले ये पिक्चर हम देख लेते हैं। ये दोनों पोजीशन है, साइड लाइन पोजीशन में या फिर सीटिंग में विद कर्लिंग अप. A small amount of local anesthesia solution is injected into surrounding skin at L2 L3 or L3 L4 prior to the insertion of the toy needle. Some women may find the technique painful, whereas others do not seem to experience pain or discomfort. Pain is usually caused by difficulties such as hitting bone. Once the toy needle is inserted, anesthetist moves it slowly from the resistance of tough interspinous ligament into epidural space. Before a dose of local anesthetic, commonly bupivacaine, a 0.25% solution is often used, is injected. Careful aspiration for blood or CSF is made. The effect of good epidural anesthesia should to block the sensory nerves and eliminate pain but leave motor power. ये वही टॉय नीडल है जिसे हम L3 L4 के दरमियान अप्रोच करते हैं, L4 L5 L2 और L3 के दरमियान या L3 L4 के दरमियान अप्रोच करते हैं। और यह सिर्फ और सिर्फ जो हमारी सेंसरी नर्व्स हैं उनको इफेक्ट करता है, मोटर को नहीं करता। साइड इफेक्ट्स और कॉम्प्लिकेशंस देखेंगे एपिड्यूरल एनेस्थीसिया की। अलोंगसाइड द सेंसरी ब्लॉकेड, द सिंपैथेटिक नर्व्स विल बी अफेक्टेड. दिस लीड्स टू vasodilation of the blood vessels in the lower abdomen and the legs, which will be warm to touch and consequent drop in blood pressure. The mother legs may feel heavy and she may be unable to move them easily. Walking will not be possible initially. The mother sometimes feel dizzy and shivering can be a nuisance. मतलब इसी की वजह से डिजीनेस और शिवरिंग की वजह से वो पेशेंट एनॉय हो जाएगा. Urinary retention may occur if the mother is unable to feel her bladder filling. She should try to maturate every 2 hours. A catheter will be passed if retention of the urine becomes obvious. The mother must be encouraged to report any loss of sensation or abnormality in maturation pattern. Accidental puncture of the dura and consequent release of CSF can give rise to severe postpartum headache. In the past, the mother was usually nursed flat for at least 24 hours, and intravenous drip of hot solution remains in place. In current practice, the drip may remain and the mother is encouraged to drink. She may not be required to remain in supine position. Many women complain of pain and tenderness postpartum at the epidural site, and for some, this can be intolerable. The women's health physiotherapist can help alleviate this problem by offering a hot pack or tents and suggesting that the mothers rest in prone lying with appropriate pillows. Neurological complications may persist following epidural anesthesia. Muscle weakness in a leg or foot, loss of sensation in an area of skin, and paralysis occur. Epidural anesthesia for the cesarean delivery. Epidural anesthesia for cesarean delivery has become an increasingly safer and more popular option. The woman is conscious and is therefore present at the birth. When preparing women for an elective cesarean section under epidural anesthesia, it is important to mention that because of the profound block required to achieve total analgesia, they may experience some side effects. Hypotension can give rise to a feeling of faintness, shivering, and vomiting can also be troublesome, and the mother may feel cold. The postnatal period, postpartum physical or mental condition. Muscles and ligaments, the body's ligaments and collagenous connective tissue will still be softer and more elastic than pre-pregnancy, and it will take 4 to 5 months for full recovery to take place. The abdominal muscles, which will have been stretched, are now elongated, and the separation between the two recti abdominis muscles, known as diastasis recti or diverification, will almost certainly be apparent in any woman who was at term prior to labor. This can vary between a small vertical gap 2 to 3 centimeter wide, 15 to 12 to 15 centimeter long, to a space measuring 12 to 20 centimeter in width and extending nearly the whole length of the recti muscle. Pelvic floor will almost certainly be weaker than it was prior to the pregnancy. The perineum itself will have been considerably stretched. It may also be cut, which is called episiotomy, or torn and then sutured with resultant bruising and edema. The women's health physiotherapist should be aware that there may be neurological damage to pelvic floor during the birthing process, resulting in temporary, days or weeks, long lasting, which involve months, or permanent loss of sensation or muscle weakness, or both. Second complication is edema. Many women will complain of heavy edematous, aching legs, swollen feet, and ankles in the immediate postpartum period that may not have been apparent before the baby was born. This may be unilateral or bilateral. The cause can only be speculated as probably prolonged pushing during labor, pelvic congestion, dysfunctional urinary tract, or the temperature on the postnatal ward. Next complication is back pain. The passage of the fetus through the pelvis and the resultant stretching and the movement of the legs joints, epidural anesthesia, lithotomy position, poor feeding, or nappy changing posture, tension and fatigue may all be the causative factors. Pain management. The women health physiotherapist must be alert to the pain of the women who have experienced intervention deliveries, as this can often prevent the mother being relaxed and comfortable. A major role of physiotherapist is to use her specialist knowledge, skills, and experience to assist in whatever way she can. For example, with sport, positioning, transcutaneous electrical nerve stimulation, ice, pulsed electromagnetic energy, pressure relieving cushions to establish breastfeeding. postnatal फिजिकल थेरेपी असेसमेंट इंडिविजुअल वर्सेस ग्रुप एजुकेशन. सबसे पहले तो हमने असेसमेंट करनी है. असेसमेंट की बेसिस पे ही हम उसका फिजियोथेरेपी प्लान जो है, प्लान ऑफ केयर, वो डिज़ाइन करेंगे. इंडिविजुअली भी कर सकते हैं हम उसका जो प्लान ऑफ केयर है, या फिर हम ग्रुप फॉर्म में भी उसकी कराएंगे. टीम वर्क में पेशेंट जो है वो ज़्यादा कर्जियस रहती हैं. वेन्यू सेलेक्ट करना है जो उसके लिए फिजिबल हो. Exercise. The new mother should be encouraged to be mobile and therefore reduce the risk of circulatory and respiratory dysfunction. सर्कुलेटरी में जैसे हमने हाइपोटेंशन देखी है, या फिर नेक्स्ट हमने इसमें देखा था हेडिक हो रहा था पेशेंट को, या फिर एडिमा हो रहा था, और रेस्पिरेटरी प्रॉब्लम्स एनेस्थीसिया रिलेटेड जैसे नमूनिया हो सकता है, एटलेक्टेसिस हो सकती है. इनको हम प्रिवेंट कर सकते हैं अगर पेशेंट अर्ली मोबाइल हो जाए. If she is confined to the bed for a prolonged period of time, then controlled and deep breathing and vigorous circulatory exercises should be encouraged. Pelvic floor muscle exercises are valuable for their strengthening and pain relieving properties. They will also speed healing by reducing edema and encouraging good circulation. और एक तो वो है जिनको हमने अर्ली मोबाइल करना है ताकि सर्कुलेटरी एंड रेस्पिरेटरी कॉम्प्लिकेशंस ना हो. सेकेंड, वो जो प्रोलॉन्ग टाइम के लिए बेड बाउंड रहे तो उनको हमने कंट्रोल्ड डीप ब्रीदिंग विगरस सर्कुलेटरी एक्सरसाइजेस करानी है, और साथ हमने पेल्विक फ्लोर मसल की स्ट्रेंथनिंग भी करानी है और पेन रिलीफ भी करना है. इनकी वजह से एडिमा भी सबसाइड हो जाएगा जो यूनिलैटरल या बायलैटरल डेवलप हो जाता है. The principles of muscle re-education should be followed when exercising the abdominal muscles, progressing from static no joint movement through to the dynamic joint movement. Commence at whichever starting position is appropriate for the individual, bearing comfort in mind, that is, side lying, prone lying, crook lying, sitting, standing. Anterior abdominal wall should be drawn in on expiration, thereby increasing the muscle tone. Then progress through to static contraction per active range of movement, that is, pelvic tilt, flexion in progressing ranges of the lumbar spine. इन सब पोजिशंस को हम देखेंगे. ये क्रुक लाइंग, प्रोन लाइंग, स्पाइन लाइंग, राइट लैटरल रिकम्बेंट, फोल्डर्स पोजीशन, लेफ्ट लैटरल रिकम्बेंट एंड टंडेलेनबर्ग पोजीशन. इसी तरह ये कुछ पोजीशन है हमारे पास. स्पाइन लाइंग, सिम्स, पोस्टीरियर व्यू है इसका. प्रोन लाइंग, नी टू चेस्ट, डोर्सल रिकम्बेंट, स्टैंडिंग, ये हमारे पास है लिथोटमी पोजीशन. ये स्क्वाटिंग हो गई नेक्स्ट, और लास्ट में हमारे पास है सिटिंग पोजीशन. थैंक यू सो मच. ये टॉपिक हमारे कंप्लीट हो गया. नेक्स्ट इंशाल्लाह मिलेंगे किसी और टॉपिक के साथ. तब तक के लिए अल्लाह हाफिज़.